focus on is a little more in depth on ways you can prevent or understand your heart health in a little more meaningful way, I think. And I'm going to focus on cholesterol, artery calcium, and we'll talk a little about dietary calcium and kind of how that impacts you. We've done this talk, I think this is our third year. This is the first year we're in the big house, the big show, so thanks for having us this way. But I think you'll get a lot of good information out of it. This will definitely build upon what Dr. Bond has talked about. Getting a hard time with that. Let me see if I can. Sometimes you have to add in this. Do I have to lean into it?
A little bit, yeah, it's super awkward.
That's okay. All right, so hopefully that's better. I'll just have to lean into this. So this is what I'm going to focus on, coronary artery disease overview. Dr. Bond did go over this a little bit. The importance of cholesterol management, how that impacts heart blockages, and that's what the coronary artery disease is, heart blockages. What this calcium score business is, you'll hear a lot about it when you haven't, and hopefully we can clarify some of these things about this. What your doctor's going to do with the calcium score when you do that testing. And then I am going to talk about some emerging risk factors that are out there and some advanced heart imaging that you can get these days that can help that you may not be aware of. So a little bit about coronary artery disease, and this is heart blockages, and I think Dr. Bond did a good job of explaining this. What happens is, as you age, you have high cholesterol and risk factors for heart disease, such as high blood pressure, diabetes, obesity, poor diet, inactivity, smoking is a big one, or even family history. You have normal heart arteries, as kind of shown up here. These are arteries or pipes. I'm a fancy plumber, is what I tell most of my patients. And if you don't have any cholesterol buildup or plaque buildup, you have nice, good blood flow in the heart arteries. What happens as you age, and these are the risk factors that are shown here, you'll see cholesterol deposits in the artery walls, and as it goes on, this leads to blockages. So the heart is a muscle that pumps, and it has to have blood. The heart pumps blood to the body, but it also pumps blood back to the heart itself to get that oxygen to pump. And blockages are the arteries, or blockages that we call heart blockages, are arteries that get blocked that supply blood to the heart itself. So that's what a heart attack is if it builds up and goes on. This is just a little bit about some interesting data, and I've got some data from the 70s and 80s, which I'll show here, but I'll also show you what it looks like in 2025. But most of the people who have heart artery blockages, heart attacks, actually have no symptoms until 24 to 48 hours before they have their event. That's a little concerning. That means there's a lot going on to develop this before you actually do get a heart attack. This data here, 40 to 50% of women actually have no prior symptoms until they show up in the emergency room with a heart attack. It's still true today. But what can happen is if the heart artery is blocked and you're not getting blood flow to your heart, this can lead to heart failure. That means the heart pump can't pump blood to the body. It can lead to arrhythmias or electrical instability of the heart, poor quality of life due to symptoms, or even sudden death, which is the most worrisome complication of a heart attack. So what are the most important risk factors? Dr. Bond really wrote that quite well. I must say, I've learned a lot as well, even as a cardiologist, things pertain to women. But what this is a study which showed what are the most important risk factors for causing a heart attack or even stroke. And what they did is, if you look at this across this chart, these are the risk factors, and these are the percent in the population of how important these risk factors are to contribute to heart disease. And what you'll see here is cholesterol is probably the most important risk factor for developing a heart artery blockage. Smoking is big as well. Psychosocial constraints are huge. Obesity, high blood pressure, or diet, all of these things contribute. I'm not trying to say one's more important than the other. If you don't have one, you can just let the others go. They all definitely contribute. But when you look at all the research and the studies, they really show that cholesterol is a huge impactor of developing heart artery blockages. It's a huge modifiable risk factor, meaning we can do something about it. And most of these risk factors here, you can do something about it to lower your risk. It's just we want to make sure we're hitting the items that can really, really lower your risk. So what does your doctor do when you come to see a preventive cardiologist or maybe even your primary care doctor, for example, and you want to know, well, what's my risk for having a heart attack or stroke? Because stroke is also in this when you look at these risk factors. What your doctor is going to do is they're going to do a risk assessment of you. They're going to look at your age, your blood pressure, maybe you have diabetes and so forth. They'll look at your risk factors and they'll put you into this calculator. And then they will basically try to determine what your risk of having a heart attack or stroke is. And then if that risk is high, they say, hey, you know what, you need to be on a cholesterol medication in addition to stop smoking and those sorts of things. And then they'll say, hey, maybe you don't need to be on a cholesterol medication. And what you'll see, and Dr. Bond really pointed this out, and I want to point this out, is that you'll see that most people will be considered to have high cholesterol when they are in these ranges. When your total cholesterol is above 200, when your LDL or bad cholesterol is above 100. But are you truly safe if you're not in this range? And I think she made a great point about the one size fits all. Not everyone who is going to be labeled as normal or healthy levels is truly normal or healthy. And I'll show you some cases towards the end about how kind of doctors use this information and some of the more in-depth things we do. But this is kind of what your doctor's going to do. And again, this is focused on someone who's never had a heart attack or stroke. We're trying to determine, are you at risk for having something? And can we get you on cholesterol medication to really reduce that risk of having something happen? If you've already had a heart attack or stroke, you're already high risk for murder, and you're already on these medications. Okay, I hope that's clear. So how are doctors doing out there? And I showed you some data from the 70s and 80s where I said most patients don't have symptoms. It's still true today. This is a study from 2025 from 2 hospitals, and they looked at all comers who had heart attacks. And they went back and they calculated their risk score. And they wanted to know, well, of all these people who had heart attacks, how many of them were on cholesterol medications and how many of them were classified as high risk? Because if I'm doing a risk assessment, you would assume that I'm going to be able to accurately predict that you're going to have a heart attack. It was extremely interesting and eye-opening that nearly half of the patients who have heart attacks are classified as low risk. So really, risk factor assessment is missing people. We're not identifying the appropriate people who need to be on cholesterol medications or who maybe need that extra coaching to really help modify lifestyle. Another thing that's also interesting, and it's in the 70s and 80s, and it's true today, most of the people you're going to meet who have a heart attack, their first symptoms will occur within 48 hours of the event. So the moral of the story here is if you're using risk factor assessment alone, or you're waiting to maybe see if you need to prevent something based on symptoms, you're going to miss a lot of people. And Dr. Bond did point out that a lot of the studies you'll see really don't include a lot of women. This study only included 20% of women, and we do need more research in this area to truly understand this. But regardless, risk factor assessment is not doing the job, and waiting for symptoms is not the way to go about this. You need to be proactive, and hopefully the information given to you today will let you be a little more proactive about your health. So what are we missing here? Why are we, when you look at these patients who have heart attacks, they come to us, why are they classified as low risk? And what's happening here is we're taking a risk score that's been developed in the population, okay? So it takes lots of patients in clinical studies, they look at risk factors, they do these fancy statistical predictive models to try to say, okay, you're at risk or you're not. Well, what's the issue here? That's you over here. Are you one of these 100? I hope you're not, who has the heart attack or so many of them. And that's the big issue, is that population risk scores are not you. So really, it's not a personalized approach to your prevention when you think about just doing a risk factor assessment alone. And that is what most doctors are doing in the US these days. Even cardiologists are doing it, and we're trying to really turn that with a lot of things you can do. Before I get into the calcium scoring, I just want to kind of give you a frame of reference here. This is data from the CDC, and these are the leading causes of death in women in 2021. And most people still don't know this, but heart disease is the leading cause of death in women. Cancer is the second cause of death, or leading cause of death. This was around COVID times, when COVID was up there as well. But really, heart disease is a big cause of death in women, and most people still don't know that, and most women as well. So when you think about cancer screening, and I'm going to kind of relay what I'm going to say about calcium scoring screening, we're trying to basically detect something before it happens. And then heart disease is no different. I want to detect it before it happens. I want to prevent it. Breast cancer starts at 40 to 45, depending on your risk factor profile. Lung cancer screening is big out there these days, if you're an ever smoker, age 50. And colon cancer screening. Everybody's quite familiar with this. These are the tests you're going to get. You're going to get a mammogram to screen for breast cancer. You're going to get a CT scan to screen for lung cancer. You're going to get a colonoscopy or some other things out there to look to see if you have an early remnants or early stages of colon cancer. Interesting part about cancer screening is all of these tools directly look at the organ in question. So I don't give you a risk score and say, this is your risk of having breast cancer, you need a mammogram or not. No, we know that breast cancer is a significant impact and morbidity and mortality in women, so we do mammograms on everyone. Well, why don't we do something like this for heart disease? Why are we doing risk factor assessment alone? I showed you we're missing a lot of people, and that's going to be my main argument today. There is more you can do, and we should be doing more to look at the heart directly to determine what is going on. So this is talking about calcium scoring, and I'll go through what that entails. But just so you know, as you age and you develop calcium or cholesterol deposits in the artery walls, and again, it's fatty stuff, it's the diabetes, high blood pressure, it leads to the cholesterol deposits in the artery, and then the artery doesn't get good blood flow to the heart itself. But as you age, it calcifies. So it becomes calcium in there. And I'll talk about dietary calcium. This is not dietary calcium, but this is just a local process of inflammation and damage to the artery walls. And what you can do with a CT scan is you can actually detect this calcium. So you can use this as a preventive screening tool to determine if you have early or late stages of the disease. You get a score, and I'll go over what that is, and a percentile. And that kind of equates to the higher the score, and that's what this shows. And again, these are pipes. The higher the score, the more likely you have a clogged pipe. And that's what a heart artery blockage is. It's a clogged pipe. So how does calcium scoring? I told you risk factor assessment. If I just put you in a calculator, I'm going to miss a lot of things. I'm not going to correctly quantify who's going to have a heart attack or a stroke. But how does calcium scoring? I mean, if I just look at the calcium score alone, and I want to see how predictive it is that you have a blockage or are going to have a heart attack. So this is just probability. Again, not a whole lot of math here or medical school training here. But basically, 0.5 is flipping the coin. If I use calcium scoring, I'm going to have a much higher probability than 0.8 of detecting someone who's going to have a heart attack. Okay, that is very predictive. That is much better than 0.5 of flipping a coin. Risk factor assessment alone is 0.55, flipping a coin. So if you see a doctor or if you see a provider who counts you on risk factor assessment for heart stuff, and they just do a risk factor assessment alone, they are flipping a coin to know if you're going to have a heart attack or not. I think that's a disservice to patients, and we just really need to get this message out there about that. What's a better way to do this? So probably a better way to do it is, just like in the cancer world, directly looking at the organ in question. So this is what we do, and again, we're not going to go all the way to medical school, but you get a CT scan, we don't give you any contrast, and we basically can determine, do you have zero calcium or calcium? And the calcium is the white stuff, and then this is a cross-section of the heart, and that's a heart artery. So this individual has no calcium in the heart arteries, and this individual does have calcium in the heart arteries. And again, what we're going to end up getting is a score, a value of this, and then it'll also kind of give us a percentile of how accelerated that score is, and that'll make sense. But you can get a lot of information, and just like cancer screening, I'm looking directly at the organ in question. I'm not guessing about what is your risk. I know this person is probably low risk, and this person is much higher risk. There's no guessing here. How do we do it? We do a CT scan. Again, there's no IV given, there's no contrast, there's no preparation. This is the scanner we have in our heart vascular tower. There's really no preparation. You just show up and get it done. You do have to hold your breath for about 5 to 7 seconds. It takes 5 minutes to complete, but the scan itself is over in a matter of seconds. It's extremely low radiation these days. I know we worry about that, especially in women, exposure radiation, but it's very minimal these days. It's really nothing to worry about. So who needs this test? And we get asked this a lot. It's a screening test, okay? So back to our medical school education here. A screening test is for someone who doesn't have symptoms. I don't want to find you later down the road. I'm trying to detect you early, okay? So I want to get you before you have symptoms. Because again, half of our heart attacks are basically going to show up and their symptoms are within the first 48 hours. So we want to get you well before that, okay? What most folks would say in most bodies or societies, the American College of Cardiology, the American Heart Association, they say if you're between 40 to 75 years of age without prior heart disease in any one of these, a strong family history of heart disease, 1 in 3 Americans die of this, you all have a strong family history of heart disease, high cholesterol, diabetes, smoking, kind of all of these risk factors we talked about, and you're in this age range, we really would like to get this test on you because it gives us so much information that is very predictive about what the state of affairs are for your heart health. So who does not need this test? So patients who have symptoms of heart disease. Again, once you have symptoms, you're probably going to get a diagnostic test, not a screening test. So if you have chest pain, shortness of breath, even some of the symptoms that Dr. Bond talked about, fatigue, low energy, those sorts of things, we're probably going to do a different test on you, a diagnostic test. There are probably women here today who have heart disease, who've had heart stents, heart surgery, and so forth. That's not something we want to see with this test. We want to see you upstream. We want to see you before you have symptoms or heart disease. Okay, so I hope that's clear. If you have heart disease, we kind of know that you need to be on a lot of these aggressive risk factor modification things. Cholesterol, lipids need to be controlled, and all those things. This is not for you. This is before you do this. So what information do you get with a calcium score test? And I always say know your risk. Okay, I think I've shown you pretty well that it's a pretty predictive tool. It's going to give you a lot more information that your doctor can use more than just risk factor assessment alone. But what you're going to get is you're going to get a value, a numerical value for the amount of calcium in your heart. You're also going to get a percentile based on age and sex and race match controls, kind of where you fall in the population. It doesn't tell you what percentage blockage you have. It just says, do you have hardening of the arteries or not, and kind of what the score is. You know, hopefully I've shown you it's a very strong predictor of heart events, more than just risk factor assessment alone. But what your doctor will do is they'll take it, and if you have a score of 0, you're very low risk. You have no hardening of the arteries. You're likely a low risk individual. If your score is above 400, you're very high risk. Okay, people with scores above 300 actually have the same risk of having a heart attack, which I'll talk about, as someone who's already had a heart attack. So the higher it is, the higher risk you are. We also use the percentile, kind of where you fall in the population, meaning if your score is above the 75th percentile, you have a score higher than 75% of women who are your age, sex, or age and race. So that means it's more than expected, because some of this can be expected as we age, but some of it is more than expected, and that's what accelerated means. And we get that information from the percentile. And again, this is just a diagram kind of showing you kind of what these scores mean. 0, probably no evidence of calcium or plaque buildup. If it's 1 to 100, we'd probably say mild range, moderate, 1 to 300 is what most people are doing these days, and then over 300 is probably extensive. And I've got another score chart here, and this is very busy, but this is kind of what doctors are doing now. This is all new data in 2024. And how I equate this is what doctors are doing is they're taking your calcium score and they're staging you. So just like you get staged for cancer, and again, I'm not downplaying the negative consequences of cancer or anything like that, but I'm saying it's the same idea, is I can take your calcium score and I can stage you. If it's 0, there's no calcium present, or mild, 1 to 99, 1 to 299, or over 75th percentile is moderate. And then if you're above 300, we're going to call that severe, and above 1,000, extensive. And so then what your doctor is going to do, if your score is 0, they'll basically give you you don't need to go on a cholesterol medication necessarily, unless there's other things you qualify for, such as very high cholesterol, very strong comorbidity of heart disease. But they may give you some counseling on, hey, you really need to work on your diet and exercise. They'll also kind of give you, and I know this is very busy, they'll give you kind of, hey, should you have it repeated or not? And most people within 3 to 7 years, if your calcium score is 0, may repeat it depending on who you are. But what are we going to do if you have calcium? So let's say it's 1 to 99, so that's that 75th percentile. We're going to give you risk factor assessment, exercise goals, and those sorts of things. But we're also going to give you a cholesterol goal, saying, hey, you don't have too much calcium, but your cholesterol should be lower than it is, and so forth. And I do want to focus on the 300 and above. If your calcium score is above 300, you have the same risk of having a heart attack as someone who's already had a heart attack, even if you've never had one. So these are when we get into high risk individuals. This is when the cholesterol needs to be lower. This is when we can basically say, hey, I've staged you. This is what your cholesterol level should be. And you should be on an aspirin. Not everyone should be on an aspirin these days. I think we're really scaling back on who we recommend aspirin for. A good way to do it is staging your calcium and giving you a cholesterol goal and saying, hey, you benefit from aspirin. If your score is above 1,000, your risk is the same as someone who's already had multiple heart attacks. It's just very extensive calcifications. We're going to really go for low LDL goals, put you on aspirin, all these things, and you may end up on some even more expensive cholesterol medications, or I shouldn't say expensive, but much more potent lipid-lowering agents out there. So that's kind of what your doctor's going to do. They're going to take your calcium score, they're going to stage you, and then they're going to basically give you a personalized approach to your prevention. Your cholesterol goals should be on aspirin. There are even some doctors saying maybe blood pressure should be based on this. We're not there yet. Dr. Bond did a good job explaining what your blood pressure should be. But where I'm going with it is this is a direct assessment of the heart arteries. I'm gonna give you a score, I'm gonna give you a personalized approach to prevention, and it's probably a better way of doing business these days than just relying on risk factor assessment alone. So what I'm gonna do next is kind of walk through some cases. These are real world cases, patients of mine, and just kind of how I've used calcium score to counsel them, and things we found that I didn't expect to find sometimes, some things you do expect to find. But really, this is just how doctors think. And that's the whole idea of this lecture is what is your doctor doing, how does he think about it? So this is a 61-year-old female and who came to see me for risk factor assessment. So they were really interested in knowing, what is my risk of heart disease? This female had normal blood pressure, normal body weight, and walks 2 miles a day, which may mirror some of the patients in the audience today or participants in the audience today. The cholesterol was considered borderline. The total was 239, HDL 60, and LDL 158. So really not that bad, but we really don't know based on this person. And then that risk score we talked about, that's really not good. The 10-year risk score of this individual having a heart attack or stroke was 4.3%. That's considered low risk. But then this patient had a very strong family history of heart disease. So they really want to know, what else can I do to know my personal risk of heart disease, and what else can I do to possibly prevent it? So we did a calcium score test. And the calcium came back at 84.1, but the 84th percentile. So calcium is present, there's hardening of the arteries, and it's accelerating. So what are we going to do with this management? If someone has a score kind of in this mild to moderate range based on percentile, we definitely want to get them on cholesterol medications, and we definitely want to give them an LDL goal. This patient's goal was less than 70. Again, we started kind of based on a risk score of 4.3%, low risk. This is definitely one of those patients who we see in these studies who has a heart attack later in life, maybe, and gets qualified as low risk early on. And that's what we want to avoid. And that's how calcium scoring really helped this patient get on the appropriate preventive therapy. So that's kind of how doctors think about it and use it. I know we're not all going to medical school today, but it's really just kind of how doctors think. And it really helps you be more informed when you see your doctor to know how they kind of think about things. So let's talk about patient 2, another patient of mine, a 67-year-old female who came to me for further risk factor or risk assessment for heart disease. So this patient does have high blood pressure that's treated. They're a little overweight, but they do walk 1 mile a day, no chest pains or trouble breathing. Again, screening. I'm not looking at patients who have symptoms. But this patient had really good cholesterol and is on no medication. Their LDL is 80, their total is 124. Everything here is like, hey, you're good. And I think their primary care doctor said, you're good to go, don't worry about it. Their risk score did come back, probably because of blood pressure, at intermediate at 8.6. So this, when you get intermediate risk scores, that's when your doctor says, well, you could be on cholesterol medication, you could, maybe we need to dig a little further or something, maybe we need some more information. This patient did have a strong family history of heart disease as well. And again, the question is, what else can I do to really know my personal risk of heart disease? Well, this was a little unsurprising to me. The calcium score came back severely elevated in the extensive range of 1,067 and the 98th percentile. Once your score is over 3 to 400, we know you're very high risk. If you're over 1,000, you're exceedingly high risk. So this patient was recommended to be on aspirin. We did give this patient a very low cholesterol goal. And again, we started at 80. Okay, remember, we would not consider this very high cholesterol, but now that we know this, 80 ain't gonna cut it. So you really gotta get the cholesterol low. This is why risk factor assessment, just kind of, I say acting blindly or looking blindly into a patient. Do you really think an LDL of 80? Most people would say it's good or at a good level, but is it really good for you? And I think this is where you can have a personalized approach to your cholesterol level and your prevention. Whenever I see a score this high, I tend to do further testing, just because I know it's such high risk to have a blockage. We actually did a contrasted CT scan for this patient, and she actually had 2 critical blockages that are associated with sudden death, and this patient got stents and never had symptoms. So it's not every patient out there. I'm not trying to scare you, but it is reality that there's a lot more you can do with the calcium score test, and it's really looking directly at the organ in question. And we do pick up a lot of these patients, and just equating this back to who has heart attacks. This is why people, half the people we meet who have heart attacks, their first symptoms are within 48 hours, because they have this brewing, and it was never known. And by the time they do have their heart attack, this is an individual who would never be seen in a preventive office most of the time. It's too late. And so that's why looking directly at the organ in question probably is a better way to do this.
So I got asked a lot last year, I think the year before, about vitamin D and calcium supplementation. And then this is some studies which have come out. And what they do is they look at, is there a risk of heart disease or accelerated heart disease with vitamin D supplementation, calcium supplements. This was an article published in the American College of Cardiology. It's a lot here, it's busy. There are benefits in calcium and vitamin D for bone health and so forth. But really what came out of that was vitamin D really has no impact on your cardiovascular health. There's a lot of studies that have looked at this, the Women's Health Initiative out of Boston and other things. And they looked at calcium. They said a lot of the studies were split, meaning some studies maybe showed an association with heart disease, dietary calcium, and that's what I'm talking about here, in the risk of developing calcium. And a lot of them didn't. So basically what they came up with was a recommendation that try to get your calcium from dietary purposes alone, but if you need to be on it, there's really no strong evidence that it's going to hurt you. There's no strong evidence it's not. So really just personalize that approach with your physician and provider about should you take a calcium supplement or not. So moral of the story is you're probably okay to take these medications. It's not going to accelerate the calcium in your heart arteries and so forth. So that can prevent one question from last year that I got a lot. So I'm going to kind of move into some novel risk factor assessment things that we're doing at Cone Health, and some advanced cardiac imaging tools that we've really helped pioneer on and really show you what risk is or not. LPA, how many people have heard of LPA? I'm just curious. A few people. So it's an emerging risk factor for heart disease. And so you've got your basic cholesterol. We kind of talked about this. And the cholesterol leads to plaque buildup and blockages in the heart arteries. But what LPA is it's a lipid-like protein. It's related to cholesterol. But what it's really associated with is really accelerated atherosclerosis or hardening of the arteries. So people can have high cholesterol, but if you have an elevated LPA value, you have exceedingly high, probably accelerated atherosclerosis for most people. What we're learning is that, I told you risk factor assessment misses a lot of people. We're not appropriately quantifying who's going to have a heart attack or stroke. This is probably another tool out there that explains things, meaning a lot of people have normal cholesterol levels, and the patients I did show you, that was kind of before we were testing LPA. When I see them back, I definitely check it on most people, but I'd always want to know if someone has these days high cholesterol or high calcium, do you have this LPA? Because we know it's just like throwing fuel to the fire. And what we're learning is that about 1 in 5 Americans actually have an elevated LPA. It does disproportionately affect women of color, just be aware of that. So that could be another explainer or explanation for the higher risk of heart disease that we're seeing. I firmly believe that, and I check it in everyone. It's a genetic marker, meaning it's not modifiable. You're kind of born with it. So whatever mom or dad may have had, you probably have it as well. It's strongly associated with heart attacks. Everyone who comes to Cone Hospital who has a heart attack gets an LPA. We probably need to be doing it in the office, Dr. Tom, because that's where we need to get you earlier before you have that heart attack, okay? We're really good about taking care of heart attacks, but we need to get better up front part of it. The Europeans, and I believe the American Association, are now recommending a once-in-a-lifetime testing just because it's so high risk if you have this. There are no therapies currently available. Some of the therapies out there do lower it, but there's no targeted therapies that say, hey, you need to be lower on this LPA, you need to be on this medication to do it, but they're in development and coming fast. So even if you've done a risk factor assessment maybe 2 or 3 years ago, come back, because things change. There's all these new things we do all the time, and I'm going to show you a case in the next slide about a patient who came back. So this was a 53-year-old patient, again, thinking about how your doctor's going to use some information. And she's 53, really healthy actually. Normal blood pressure, normal body weight, walks 4 miles a day, more than me. Cholesterol really was not that bad. Very low risk by traditional risk factor assessment, 1.4%, but does have a family history of heart disease. So really, I think it was 2 years ago we did a calcium score on the patient. It was 0. I said, look, you're low risk. You probably don't need to be on anything at this time. But she came back actually a few weeks ago, and she said, hey, I'm back, what's new, what's out there? And I said, you know what, let's check your LPA, because you have a very strong family history of heart disease, let's just see where you are. I had already kind of told her, based on her risk factors, she should repeat it in 5 years. But when she came back, I said, let's check your LPA. And her LPA was very elevated. So she's one of those individuals who probably has all these risks of heart disease we don't even know about, because we didn't check it before about 1 to 2 years ago. And based on her LPA being elevated at 205, normal more than 75, I did recommend cholesterol medication and gave her a dollar. So I think this is another tool out there. It's another emerging marker of heart disease that you can use when you see your primary doctor. It probably is going to be modifiable in the future. So come back if you've done a risk factor assessment and maybe you need to get reevaluated because things are changing all the time and very rapidly. So the last few things I'm going to talk about are just some kind of newer things that you can do for risk factor assessment. Not so much prime time, but Cohen's been really leading the way in this. And again, we're going back to medical school. Maybe we're in our last year of medical school learning this. But this is a CT scan with contrast of the heart arteries. And sometimes a picture is worth 1,000 words, okay? Because this is what the doctor sees, this is what we're looking at, and this is what we can do. If we do a CT scan with contrast, we can actually directly look at the heart arteries in more detail. And I can tell you if you have calcium, I can tell you if you have non-calcified plaque, soft plaque, cholesterol buildup, and then I can tell you if you have a blockage or not. So let's just walk through this. This is a patient here who has normal heart arteries, and again, I'm a fancy plumber. There's no blockage here. The artery's open, the blood flow's good. I think, if you think about this as a pipe, it's very simple to see this pipe is open. This is someone who has a little bit of calcium. There's no blockage, but I can get blood flow through that artery, and I can see there's some calcium, but no blockage. We call that minimal. This is someone who has mild plaque or mild calcium. Again, it's only reduced by about 30% or so, but not a significant reduction. In the red here, this is late disease, and all of these patients are early disease. But this is someone who's got a lot of, and I say, when you think about this, lumpy, bumpy, the pipes have a little bit of plaque in it. There's probably no reduction in blood flow here, but there's a lot of gunk in there, and that's what cholesterol deposits are. It's gunk. It's cholesterol buildup, it's calcium buildup. This is someone who's got a critical blockage, and then this is someone who has a completely blocked artery. These are all patients of mine. They all walked in my office. It's kind of interesting, they all had symptoms of chest pain, but you can basically have chest pain symptoms and never have a heart attack but have a critical blockage. And that's the idea here. When I directly look at your arteries with this, there's no guessing. Okay, I know you've got a plaque buildup, I know you've got a blockage, and I can really either get you to get a procedure if you're in this case, in these two categories, or early stuff. And I think now where we are with CT scans, we're taking it a step further with contrast. We can look directly at the arteries, just like the cancer screening we talked about. And we can really know what your risk of event is, or if you've already possibly even had one. So it's a lot of good information you can get. Just with the CT scan, just because the diagrams I showed you, there's always calcified plaque and there's non-calcified plaque. So what happens is this kind of soft cholesterol plaque builds up, like we said, and then as the arteries get a little more clogged and then more cholesterol, and it calcifies, okay? But what we know is that calcium is actually stable plaque. And calcium is the tip of the iceberg. So if patients have calcium, we know that they have a lot more plaque in their system, in their arteries, and it's non-calcified plaque. So with a CT scan with contrast, you can actually see this in great detail. I can see the calcified plaque, I can see the non-calcified plaque. And the nice thing about this is it's a very predictive tool to know even further what your risk of heart disease is. So this is the assessment we give at Cone. Cone actually is the first in North Carolina to provide this assessment. It's called a quantitative plaque analysis, just a fancy term to say basically I'm going to take your CT scan with contrast, and this is a female patient who's got a lot of calcium, but a lot of non-calcified plaque. And I'm going to take your plaque and I'm going to quantify it. I'm going to give you a score, and I'm going to give you a percentile, just like the calcium score, but I'm going to take it a step further, okay? And just focus here. This patient has 37% of their plaque is calcified. That's the tip of the iceberg. What we often see when we do this scan and this assessment is that the majority of your plaque is non-calcified plaque. So in most of my patients who have an elevated calcium score, I tend to go on to do this because I know this test is going to let me know the true state of affairs. This is the most predictive thing you can do. So, and not everyone's going to get this test. This is new. Cone Health has really worked hard to pioneer in this. Again, we're the first in the state to offer it. We're a leader in the CT arena, in CT space. That's why I'm here talking to you today. But what you can also do, there's other things you can do even if you have a high calcium score. We can directly look at your arteries with a CT scan. I can give you a total plaque assessment, calcified, non-calcified. And it's more predictive of a heart attack than risk factors, clearly, but it's also more predictive than calcium scores or percent blockage. So if you take a step further, just going back to our argument or discussion on calcium screening, or screening for cancer, you know, all of the cancer screening directly looks at your arteries. Why are we not doing this for heart disease? I really don't know. I mean, I talk to a lot of people about this. You get in front of insurance companies, they don't want to pay for things, they want more clinical trials. But really, this is probably the most personalized approach to your heart health prevention you could do. And it's a little hard to get with the contrasted scan. So it's really a shame and a disservice that we have to fight so hard for the #1 killer of women out there. And we really, I think, what I've tried to impress upon you today is that the way we've been doing it, we're not doing something right. And it's probably because we're just looking at risk factors alone, and we're not looking directly at the problem, which is your heart. Okay? So just think about that. And the last, before we kind of go through, you know, calcium scoring, where you can get it done, those sorts of things. And again, this was just kind of talk about some of the fancier things you can do. This was a patient of mine, and this was actually, we've been using this plaque analysis and this tool on the contrasted CT scans for about 3 years. It's now commercially available here as well. But this was a patient of mine who basically had a CT scan, I want to say 6 months before her cardiac arrest, before she had a heart attack and passed away. And this was before we even knew what to do with this plaque tool. And she had a calcium score of 0. So we thought, oh, low risk. But then we went back after she had this event, and we looked at her CT scan, and we did this analysis. And again, we didn't have this plaque analysis at the time. And we wanted to know what happened. And when we did the plaque analysis, again, no calcified plaque. But look at, there's a non-calcified plaque of 193, and then there's this, we can take it even further, look at like a really fatty plaque. But basically, this patient was thought to be low risk, but when you actually look at the total plaque assessment, they're very high risk, and this patient had a heart attack and passed away. So where I'm going with this is we talked about risk factor assessment, really how we can assess your risk. Do you need to be on cholesterol medication? What's your risk of having a heart attack? That's not going to cut it, okay? And then we can look at calcium score, that's even better. But even a calcium score of 0, you can have non-calcified plaque and have a heart attack. And that's all I'm trying to impress upon you today, is that, you know, when you go talk to your doctor, ask these questions. Hey, should I get a calcium score? Should I get a CT scan with contrast? Should I get an LPA test? What can I do? So really, you know, just to kind of conclude on this, before we take questions, you know, cholesterol is the most important risk factor for heart attacks, okay? All the other risk factors are extremely important. You shouldn't be smoking. If your cholesterol is good, is it good for you? And I think Dr. Bond really hit this well, is that we really need to individualize our approach to you. Meaning, if your cholesterol is pretty good, is it good? You know, can we do a little more testing? That's the whole idea here. You've got calcium scoring, LPA, and even a CT scan with contrast. Because we know risk factor assessment is going to miss a lot of patients, and I see this all the time, and it really frustrates me. Because basically, if you just rely on risk factors, you're flipping a coin. You're flipping a coin to know if you're going to have a heart attack or stroke. If you're waiting for symptoms, again, most symptoms occur within 48 hours, that's too late as well. So with calcium scoring, we can directly look at the arteries for early and late disease. And then even with these kind of newer therapies, which you can get at home, the LPA test and even a CT scan with contrast can really risk stratify you even further. And it's really, you know, the take home is the direct imaging of the heart is the best approach to guide prevention. I think we're getting there slowly. I think Cone actually does a great job of it. But really, I see a lot of patients, and I think we could be doing a lot better with this. So I'll conclude there on that. I am going to just update you about calcium scoring, about how we can get it done. You know, the enforcement news, and again, I continue to write my letters to the government. It's not covered by most insurance plans in North Carolina. Most insurers and providers consider the calcium score test to be investigational. It is really sad. But because of that and the importance of it, Cone Health offers it for $99 as a self-pay price out of pocket. I really hate that because I think $99 is still a lot of money to a lot of people, okay? So it really disenfranchises a lot of patients. And Cone has done a lot to try to remove that barrier. So there are ways, there's assistance programs through Cone, so don't let that stop you. Please do talk to us, and we can maybe assist you with that, because we really want to do our you know, I think this is a big thing and a big way to offer equitable care out there, and we really should be doing a better job of this. You're actually able to sign up today. Sarah Wallace, just raise your hand, Sarah. She's one of our CT, or our advanced imaging program coordinator for cardiology at Cone Health. She's got a booth outside. You're able to sign up for it. And then there are various sites throughout the health system you can get it done. There's actually 11 now. These are all the sites where you can get it done. You can even get it done at our new heart and vascular tower, the Bell Heart and Vascular Center. We have a dedicated CT scanner in there. If you need, more in-depth testing, it could be done in different places, but, cone can get it done in most places very well. So I'll stop there, and then Sarah, do you want to just give a brief talk about how you can sign up for the exam today, and kind of what that might entail?
Yeah. So, like you said, my name's Sarah Wallace. I'm the program coordinator for our cardiac imaging program, and literally Dr. O'Neill's right hand. But I've got these flyers. I've tried to pass out several of them to early participants of this lecture, but if you need one, I've got more. But I do have a table outside, just outside the auditorium here, and a laptop. I can sign you up for these $99 tests and actually go ahead and get you scheduled at any of the 11 locations throughout our system. But yeah, I hope to see you out at my booth. Thank you for coming.